All right, so we are going to talk about the drugs for heart failure in the second part of this video. So here's a visual that kind of runs us through the main drugs that are going to be used to either prevent or treat or manage symptoms of heart failure. We're not going to spend a lot of time talking about all of them. I'm going to kind of pick and choose a few, but they all have some utility. So starting up at the top here, here's our drugs that are going to affect the sympathetic nervous system. So what we're going to want to do here is inhibit the sympathetic nervous system. So this is where the beta blockers would plug in. They're going to decrease cardiac work by slowing down the heart, and that's going to be mediated mainly by the beta-1 receptor. And if we have a sympathetic drug blocker, that's going to both hit the beta receptors and the alpha receptors, which many of them do. They're primarily beta blockers, but they have some alpha activity. That would also decrease blood pressure. And an example of that is carvedilol, or Coreg is the brand name there. Then I'm going to go down here for a minute. Here's our cardiac glycosides. These are kind of were the prototype drugs for heart failure, the oldest drugs for heart failure. These are the DIG drugs. The example is digoxin. They're going to decrease cardiac output by increasing the force of contraction. So these are positive inotropic drugs. Then I'm going to come over here for a minute. These are the ACE inhibitors and the angiotensin receptor blockers. These have become the drug of choice, and they're going to also increase cardiac output and lower blood pressure, and they're going to do this by decreasing blood volume, and they're going to interfere with that renin-angiotensin-aldosterone system. So an example there is lisinopril. Diuretics are oftentimes used, especially once the diagnosis is made and they're dealing with some fluid overload. And they're going to decrease cardiac output by reducing fluid volume, increasing diuresis. And furosemide or Lasix is the most well-known for that purpose, and it's a quite potent diuretic. We've got straight-up vasodilators up there on the top right. Those are they're going to decrease work by dilating vessels and reducing preload. And then kind of the newest on the block are the phosphodiesterase inhibitors in the middle here. And those are going to increase cardiac output by increasing the force of myocardial contraction as well. So those are kind of the approaches, potentials. So I want to break down and talk about these individually, starting with ACE inhibitors. So ACE inhibitors are angiotensin converting inhibitors. We'll see these drugs again when we talk about heart hypertension. So lisinopril is an example of one. In terms of how they work, they are going to interfere with they're going to block the angiotensin converting enzyme. And so the angiotensin converting enzyme is the enzyme that's responsible for ultimately the effects of angiotensin 2 and also the ultimate release of aldosterone. So the ACE inhibitors do both. They reduce the vasoconstriction mediated by angiotensin 2, and they reduce the effects of aldosterone. And we talked in the previous video about what angiotensin 2 and aldosterone seem to be doing directly to the heart, right, in terms of being kind of myotoxic, if you will, causing fibrosis and maybe myocyte death and all that kind of stuff, hypertrophy, etc. So that's good. Less remodeling we see with the ACE inhibitors. They're also used to prevent myocardial infarction and protect the heart during a myocardial infarction. There's another group of drugs called the angiotensin receptor blockers, or the ARBs, that are going to work almost exactly the same way. I'll talk about those in more detail when we do the hypertension portion. But those could be substituted, and they're essentially got the same efficacy. That they're actually have a little bit of a lesser side effect profile, so they're more or less synonymous, and the mechanism would be the same. The adverse effects here are relatively minimal. They can cause hypotension, mostly because they reduce vasoconstriction and also decrease fluid volume to some degree. They can cause functional renal insufficiency, so we might want to be a little bit cautious with people with pre-existing kidney disease. They rarely, but it's possible for them to cause angioedema, which is like swelling of the lips and the airway, like similar to what you see with anaphylaxis. That's rare, but it's a possibility. They do cause cough, and that's probably the most common and aggravating symptom. It's just aggravating, not dangerous per se, but this sort of chronic sort of allergic type of a cough. Sometimes people get their nose runs as well. And they can also cause hyperkalemia, and that's due to the diuresis effect. So for the most part, they're pretty safe. Cough being the main symptom, which is much more of an aggravation than it is really a worry. We would want to be careful with somebody who already has high levels of potassium, hyperkalemia, or if they have a history of angioedema. They'd be something that we would consider being a little bit more aware of. You can see at the bottom that these drugs have become the drug of choice for heart failure. They've replaced this next type of drug, which are the cardiac glycosides. These are the ones that are listed first in your book. So cardiac glycosides, up until the ACE inhibitors came on the scene, these were the mainstay of therapy. They're extracted from the digitalis purpura plant, or the foxglove plant. There's purple foxglove and white foxglove, very pretty bell-shaped flowers. The two main cardiac glycosides that have been synthesized from that plant are digoxin, brand name Linoxin, or digitoxin. Digitoxin has a longer half-life. They are going to increase the contractility of the heart, and so they're referred to as positive inotropic drugs, and they decrease the rate of contraction and the force of contraction. So they're, they don't decrease the force of contraction, they decrease the rate of contraction. So they're negative chronotropic and dromotropic drugs. So the cardiac glycosides, because they have a narrow therapeutic index, if you recall, those are the dose that helps and the dose that harms isn't very far away from one another. And so for that reason, these drugs really now are kind of limited to late stage heart failure. And if you recall that picture I showed you in the previous slide where we looked at the stages, we didn't see the cardiac glycosides on the scene until we got to, I believe, stage 3 or 4. But stage 3, I think, is where we started to see them being used with more frequency. So they're generally used later in the game, or maybe in combination with other drugs. Cardiac glycosides also have the ability to, because they slow the heart rate down, they have the ability to be used for some of our dysrhythmias as well. And if you've watched those videos already, you might know that. So the dysrhythmias that cardiac glycosides seem to be helpful for are the atrial dysrhythmias. So that's what supraventricular tachyarrhythmias means. It's an abnormality that is is above the ventricles, so in the atria, and resulting in a fast heart rate or rhythm. And these cardiac glycosides have the ability to stabilize that particular type of arrhythmia. They also have the propensity to cause an additional ventricular arrhythmia, which is not very helpful. So, and the other thing I want to mention is they have to be used at a little bit of a higher dose in order to get this dysrhythmic action. And because of this narrow therapeutic window, that sometimes is a challenge. So if given the option, you might choose a different drug that is also indicated for supraventricular tachycardias. But this is one of the therapeutic uses for cardiac glycosides. So the therapeutic uses for cardiac glycosides that you want to remember are both heart failure and atrial dysrhythmia. So I mentioned already that they have this very therapeutic window. Actually, one of the worst margins of safety. Doesn't mean it's a bad drug. It just means they have to be really used with caution. The doses are going to have to be carefully adjusted, oftentimes on a patient-to-patient basis. Often they just need a really small dose, but one thing we do know is that for the most part, these drugs are fairly highly protein bound. So oftentimes you have to give them like a loading dose, which oftentimes they refer to as the digitizing dose, and then the dose would be dropped down, and the loading dose would saturate those protein carriers, if you will, and then the small dose there would sort of maintain them. So that's something that's sort of interesting and good to note about cardiac glycosides. How they actually are working is they cause an increase in the release of intracellular calcium, which increases contractility, moves calcium into the muscles, which actually slows down the conduction. So you're increasing the force of contraction and slowing conduction. They do inhibit the sympathetic nervous system, and they increase the parasympathetic nervous system by accentuating the vagal tone. And the vagus nerve, of course, is the primary parasympathetic nerve that's going to hit those muscarinic receptors at the SA node and the AV node, slowing down the heart rate. One of the adverse effects I mentioned previously is the ventricular dysrhythmia, and that can be a big deal. You can see that can cause sudden cardiac death. And there's a particular type of presentation on the EKG. I'm going to show you on the next slide the picture. It's called Bigeminy, and that indicates toxicity. Another thing that can happen with cardiac glycosides and really all anti-arrhythmia agents is they can cause an AV, atrioventricular block. So for that reason, they're going to be monitored both because of the dose and also monitored via EKG to make sure that this is not happening. In terms of just sort of symptoms, adverse side effects, they just oftentimes don't feel that good. You can see it's just sort of general malaise. They're dizzy, they're tired, they lose their appetite, they have headaches, nausea, vomiting. There is kind of an interesting adverse effect that's notable, and that it causes visual changes, unusual visual changes. Sometimes people will see like halos around things, like a fuzzy ring around things, or they'll change their ability to perceive color. Sometimes everything will look kind of yellow, or everything will look sort of green, or they'll just be incredibly sensitive to light. That's what photophobia is all about. So this is kind of what Bigeminy looks like on EKG, and it's just basically this continuous alteration of short beats and long beats. So when you look at that, you can see like there's these short beats in here, followed by these long drag out beats. So short, long, short, long, short, long. You can see that. That's a sign of toxicity with the cardiac glycosides. And so they're going to want to watch the ventricles very closely with these drugs. You're going to really want to make sure they don't throw them into a ventricular arrhythmia. All right, in terms of what we want to be aware of and careful about, so between contraindications and or cautions, if someone's had a heart attack recently, we need to kind of be careful in general. If they already have a ventricular tachycardia, these drugs would not be a good choice. If they already have a partial heart block because of the propensity for them to cause heart block. One thing with these drugs is it seems that these drugs can cause a fibrillation that doesn't respond to further cardiac shocks. So that's not so good. You need to be cautious with giving them calcium because that can be synergistic with a cardiac glycoside and make the cardiac glycoside effects more pronounced. Very careful with people with potassium imbalances, specifically people on diuretics, which a lot of people with advanced heart failure are going to be on. Because these drugs have a narrow therapeutic window, and some of them have a relatively long half-life, we need to be careful that with people that have kidney disease or liver disease, because their ability to metabolize and eliminate these drugs could be potentially be already compromised, and the levels can go up pretty high. In terms of drug interactions, you can see there's lots. So this is just some few, but some things that we would want to think about. They're tricky with diuretics, like I just said, because of the fact that diuretics oftentimes cause potassium depletion, and that can really make these drugs more dangerous. If they're on a beta blocker, these can kind of act synergistically with them and to have additive effects, meaning that they slow the heart rate down even more than either one would do on their own. Phenobarbital is a drug that is used as a anti-seizure medication, and that can cause the cardiac glycoside to be broken down quickly, decreasing its effect. And also antacids and cholesterol-lowering drugs can decrease the absorption of the drug, so they might need to have more. So those are just some of the things to sort of think about with cardiac glycosides. And again, these were the prototype drugs for heart failure prior to the advent of ACE inhibitors. Just really quickly, I want to just run you through a couple other options for heart failure. The first is beta blockers. And again, there's beta blockers, solely beta blockers, and there's beta blockers with some alpha blocking effects as well, which is what carvedilol and metoprolol are all about down there. So essentially what these guys are going to do is they're going to block that excessive stimulation of the sympathetic nervous system, slowing the heart rate down, decreasing blood pressure, decreasing cardiac work. It does seem in some cases that we can see a reverse of the remodeling of the heart with some of these drugs, specifically with carvedilol. And we may see also a decrease in the hospitalization and ultimate death with the addition of beta blockers. Vasodilators are oftentimes used as well, also kind of at the tail end. We saw them being added in there in like the stage 4. Vasodilators are going to reduce symptoms by reducing preload and or afterload. So you can see there's a hydralazine with isosorbide dinitrate or Bidil, and that's been approved to be an adjunct to standard therapy, and it's notable because it seems to be especially helpful in treating African Americans who have a higher incidence of heart failure. So that particular combination seems to be helpful for that population. Diuretics are just going to decrease fluid volume, and we're going to talk a lot more about diuretics in later units and a little bit with that in the hypertension conversation as well. And then finally, our last one here are the newest of the drugs on this list, and those are the phosphodiesterase inhibitors. Those drugs exhibit a positive inotropic effect like cardiac glycosides and also a vasodilatory effect. They have some pretty serious adverse effects, so they're going to be used for just a little while. And the biggest thing that we need to be careful with these patients on these drugs is ventricular dysrhythmias, and also pretty severe hypotension, low blood potassium, low platelet count, and potentially an excessive dilation of the heart, which is going to really weaken the heart muscle. So that's the story on these drugs for heart failure, and I hope that helped. Finally, really quickly, here's our kind of just a quick look at the drugs that we just talked about as drugs for advanced heart failure. And you're not responsible for knowing all this. I just kind of wanted to give you this as a reference slide. But you can see the beta adrenergic agonists there. So a beta adrenergic agonist. So now these things are going to get the heart pumping, right? So we're like looking at a heart that's not able to actually contract at this point. So that's an option. Phosphodiesterase inhibitors are what we just talked about. You can see them over there. And then the vasodilator that I mentioned in the very beginning of our conversation. Okay, that's the summary of the heart failure drugs. And I hope that's helpful. We'll come back with many more different topics on cardiovascular medicine. I'll see you guys later. Have a good day.